that are required to complete as part of orientation. The Musculoskeletal Injury Prevention course is the first in the series with workplace health and safety that are needed to be completed. So musculoskeletal injury prevention is the core prerequisite to taking It's Your Move, both the initial participant session, the annual refresher part 1. And then as part of your orientation to the neuro units, we will cover a hands-on demonstration of 4 different transfers while you're on shift in your buddy shifts or while you're working to complete that second portion. So we're going to go through some, just a quick overview reminders of some of the key information that is in It's Your Move. So this is a program that was designed and aimed at preventing worker injuries. This is the provincial program for all of us who provide direct patient care. The objectives of the course are to understand our own responsibilities in terms of looking for potential hazards and assessing those hazards, identifying the principles of good body mechanics, knowing how to assess the areas, both self-environment and the patient or client, and then the use of how to communicate the findings of those assessments into the type of manual work that we do with our patients. So the philosophy of It's Your Move is that we want to maximize the amount that the patient or client is participating and assisting. We want to maximize the equipment that we use in order to minimize the physical effort required for us as healthcare providers. And this should equal that there's no unsafe lift that occurs. So MSIs, the reason that we cover this and just hit a couple of highlights is understanding that really prevention is the key. So these are injuries to your muscles, joints, tendons, soft tissues, and slips, trips, and falls are the leading cause of MSIs in AHS, according to their statistics. So just a quick question, have you had a chance to, or have you encountered, where do we report workplace injuries? And the answer is in my safety net. So in order to complete a manual patient transfer safely, there are these pieces that we need to do. Looking at hazard assessment, doing an observational assessment of the situation, the client, and of ourselves, and knowing how to apply those principles of good body mechanics. So ultimately, it's your skill at assessing the situation every time that will result in you making a good decision and being safe. So we assess, we make a plan, and then we do the task. So in terms of understanding hazards, risks, risk factors, again, just reinforcing that we all have to take personal responsibility to identify and control hazards and to report hazards to make sure that everybody is working safely. Some of the areas that we encounter when it comes to hazards, biological hazard includes blood, body fluids coming from our patients. We have the physical hazard of the physical work that we are doing, so the manual work with our patients, as well as other working with equipment. The psychological hazard is those where we encounter potential harassment, violence, either horizontal violence amongst coworkers or from patients or family members. And this can escalate, and be as subtle as sarcasm and inappropriate comments to the threat of physical violence. And the last is the chemical hazard. So this is both like cleaning products as well as some of the medications that we administer to our patients. So as a healthcare aide, it's very important to understand your responsibility and to know how to access the information when a patient is on hazardous medication precautions, and how do you need to care for them in terms of their elimination needs. So performing your assessment, so these are the 3 areas we assess ourselves, how we're doing, the environment, is there any risks or things that contribute to the situation, as well as the patient or client. So when we're thinking about a healthy body position or body mechanics, is an older terminology. Working safe means that it is important to be warm, the large muscle groups. Make sure that we are using our 3 for the top, 3 for the bottom when it comes to doing movement techniques, adjusting your height, work height, and the setup in order to make sure that it is the safest setup to maintain the proper body position, and making sure that we use the most appropriate equipment for the task at hand. So here's what that good posture looks like. So what is important is the neutral spine. Use your hips for bending, have your knees bent slightly, a good wide base, and your ears, shoulders, and heels are in alignment. Another picture of those 6 checkpoints. So when we divide it into 3 for the top, 3 for the bottom, ears, shoulder, hips in a straight line. Again, neutral for our elbows is parallel to our body, elbows tucked to our side, and an underhand grip is strongest, palms up. And the 3 for the bottom is that your hips, knees, and the weight is in your heels and able to do a really good effective weight transfer. So we talk about that work height or comfort zone. It really is important that we match up so that it's comfortable for everybody involved. They recommend, raising the height to accommodate the tallest worker, but really what's important is that we collaborate and we communicate with each other so that everyone feels that they're at their comfort zone height. So also really important, like I mentioned, is communication. So in this instance, we say that we want a boss or someone to give the command word when it comes to preparing to do any manual transfers. So we need to make sure that both the people who are our colleagues working with us, as well as the patient involved, know what the plan is, know what the command word will be, so that we can all work together. Preparing for manual transfers, it is important to pay attention to the bed height. So when we are transferring from a wheelchair to bed, we want to make sure the patient can pivot and plant their feet on the floor if they are participating in that manual transfer. We also have to take into consideration if there's one side of the body that is weaker than the other, or if there is any type of injury that we want to make sure we are not having the patient put weight on that side. A reminder about seat belts. So we want to use them when the patient is in the chair, but we also need to remember to undo them when we go to take them out of the chair. In order for the seatbelt to fit properly, having their bottom all the way back in the chair is very important. Just like a car seatbelt, we want it to go across the lap, not across the abdomen. When we recognize using the chairs, that brakes are very important. Brakes must be applied before we put anybody into a wheelchair. And it's important to not crush the brake handles on this example is a custom wheelchair set up in the hospital for a patient. And sometimes they have these extendable handles. And when we flip the footrest back, we can crush or damage these handles. Armrests, if able to, remove them out of the way. This makes a big difference when it comes to that manual transfer. It's less height that you have to go up and over to get from chair to bed or bed to chair. When it comes to do the transfer, that is when we bring the hips forward. It's important so that we can create that weight shift and for the patient to be able to actually use their quadriceps muscles to participate in standing up. When we're doing manual transfers, it's also important to remember that we need something to hang on to help balance or stabilize the patient, but recognizing that transfer belts traditionally sometimes are used to lift the patient. However, that is not what they are intended for. They are for helping guide, swing, shift the patient's weight slightly in order to maintain balance. We're going to watch a couple of videos. So the first is an example of an ineffective transfer. So what do we see happening here? We saw a scoop under the affected arm. They went the direction towards the weaker side, which we do not want to do. They did not have the chair close. They had quite a distance to travel. And so we're going to watch again now in a different setup. The chair is close, footrest out of the way, armrest is out of the way. They're in close. They're having the patient participate. They used a command word, went 1, 2, 3, and there was no scooping or lifting of that weak arm. So one more reminder, do not use the patient's arms for leverage to lift, pull, tug. It's very important. We can support it, but we can't not scoop and lift in that armpit area. So the type of transfers that we use in neurosciences, we use the total mechanical lifts, both the ceiling lifts and the materials on wheels, the sit-to-stand mechanical lift, lateral transfer boards, and we use the roll board with the cocoon method. We also use hard boards. We have tools for repositioning. So we have the ergoglider sheets as well as Swift sheets. And then we have 1 or 2 person assist with transfer belts, 1 person minimal assist standby, also still using a transfer belt. So how do you know what transfer you should choose? It's always best to gauge and remember safety first. The safe way is the best way to go. So sometimes that might mean not doing a manual transfer. So some manual transfers are not going to equal a therapeutic transfer. We do want patients participating and gaining strength and gaining independence in their mobility. But if the patient is fatigued or if there's something going on that would prevent it from being safe, then it is better not to do a manual transfer. That's where we can bring in the equipment. If it's end of the day, patient is tired, doesn't think that, or you don't think that they would be able to do or be the most safe with a pivot transfer, that is where we can use the sit to stand lift or a sling lift. We also have to pay attention to the effect that repositioning has. It's a high-risk activity, and it's one of the things that can cause significant, injury to workers with repetitive work. So sometimes when injury happens, lack of equipment, lack of client participation, poor communication, and the repetitive nature of it are some of the things that are explained as reasons. Repositioning, so boosts and turns. What we can see here is an array of equipment that we can use to do this repositioning in bed. So you probably have encountered along in your work at some point as a student or as a healthcare aide working that there are the nylon maxi slides or something very similar to this. So these are nylon fabric, extend the length of the patient, slippery, goes between the patient and the linens and the bed surface and helps glide the patient up in bed. Then we have an example of the turn and position system, which we also will spend a little bit more time talking about. And this provides also that slippery nylon surface for ease of repositioning boosting. The ergoglider is the blue plastic sheet that looks a bit like a garbage bag, comes off a big roll. And these are often stored in the utility rooms. The benefit to these are for vertical repositioning in bed, so up towards the head or down towards the feet. And we use these primarily when a patient is on isolation, because then we aren't taking a roller board or other materials into the room that then have to be very thoroughly cleansed in order to be used on anybody else. You can see in the lower left corner is a repositioning sling. So this is a sling used with the ceiling lift system, and it allows the patient to remain laying flat and provides a really good opportunity for, boosting up in bed, changing the sheets, shifting from one bed surface to another. And then the last is showing a Swift sheet, or repositioning or slider sheet are also called. And the blue side is, again, nylon fabric is slippery, and we use that with the patient laying on it in order to provide that friction reduction for that boosting and turning. So a little bit more information about how to use the Swift sheets. Instead of reaching out to the corners and hanging onto the edges, it's recommended that you roll the sheet up and have it in tight and close to the patient to provide you with that opportunity to get a good underhand grip on it. And you want your knuckles to stay on the bed surface. So we're not lifting, we are just gliding. And the most important is to tuck that Swift sheet in again after you're done repositioning, because it is a bit slippery. We don't want the patient to slide back down in bed. So when do we not use a Swift sheet? When the patient is completely independent with their mobility and don't require repositioning. If they're independent and if they do have a little element of incontinence, then we use disposable soakers. We don't need something to lift them again or reposition, just something to catch the wetness. And then if they do need some repositioning, but they're a total care patient or significantly at risk and their Braden is less than 18 and they have, an element of incontinence or they're very diaphoretic, then we actually shift all the way to the turn and position system. And we find it works best when we use just a flat sheet underneath. So when it comes to lateral transfers, our first choice is the roll boards. The Samrit version shown here is one brand. However, the principle of them is that they have a hard surface, but they have slippery Teflon between the two layers, and then a vinyl or wipeable surface that rolls on itself in order to help us do this lateral transfer. Our second choice is that we can use a hard plastic board, and this can again provide support as a bridging device. It is somewhat slippery, but the roll boards are a better option. When we're using the roll board, we use this cocoon method. So what does this mean? We wrap the patient up in the fitted sheet. So we use the sheet from the bed or stretcher surface that they are going to. And so we bring our other surface to the workspace without another sheet on it. We don't need a second fitted or flat sheet. So we put the roller board in before we put the two surfaces together. So we prepare the patient, we cocoon them, and we put the roll board in. Then we bring the stretcher or bed in place and prepare to put the patient across. So this also is unique in that you may have encountered before reaching in a pulling motion, but here it is a pushing motion, creating momentum using your legs that actually helps bring that patient across. So with a gentle nudge, they will slide quite easily on that roll board over to the other surface, and the second worker can hang on, but shouldn't be using a significant amount of upper body strength to pull. They are just receiving the patient. And just a reminder that receiving surface doesn't need or should not have any linens. When we use mechanical lifts, so we can use these for lateral transfers, for repositioning, and then also getting up off of a surface and onto another. So we need to make sure we're using the right sling for the right patient, and so the size, weight category for that patient. We need to make sure we're using the right sling for the right equipment. So the sling that goes with either the ceiling lift system or the mobile portable system. And we need to make sure that if we're using a repositioning sling without the lift, so using this as a repositioning device, then we need to make sure we have something underneath the patient to provide that bridge. So a roller board or a hard board if you're going to do just that lateral transfer sliding across. Why do we care about not scooping under the shoulder? It's really important to understand that our patients are at risk of potentially serious shoulder complications because of that weakness they have present. So you can see this picture of the shoulder area that there's quite a bit of structures in this very small area. So this is the end of the collarbone or the acromion. This is the top of the arm bone, so the head of the humerus bone, and this is the shoulder blade in the back. And so what we see happening here is that there are bursa, there's tendons, and impingement is the term when this bone squishes the things in between it and the acromion here, the end of the clavicle, and it can cause nerve damage for that patient. And also, you'll hear the term subluxation, perhaps. And so what they mean by this is that there is a loss of contact between the head of the humerus and that shoulder joint. So it's actually dislocated slightly because the muscles are weak and they can't hold the arm in its normal position. So when we have this subluxation or this gap that may show up between the arm bone and then the rest of the shoulder, then that doesn't necessarily mean that they will for sure have pain, but definitely it's a red flag that they could end up with a painful syndrome as a result of having that dislocation. So that is why it's important that we don't use that shoulder or their arm, because we can actually make that subluxation or that dislocation worse. Or if we push up on the arm or lift it above the height of the shoulder, then that's when we can cause that impingement or the pinching of those structures in the shoulder. These are a few posters that we do provide you, as well as they are available on the units when it comes time to help with some ideas and suggestions for how to position these patients. You will have seen these as well in the first video presentation talking about our stroke patients and our patients with spinal cord injury, and how do we do our best to support those affected limbs. So when it comes to the It's Your Move program, we talked about that there would be 4 transfer types that we would have you demonstrate, and that we would mark that then off as having completed your It's Your Move component. So what we ask you to do is demonstrate with us repositioning in bed, and that could include also with the turn and position system and how to position with hemiplegia. Have you demonstrate or assist with lateral transfers, so from bed to stretcher, preferably using that roll board and the cocoon method. As the opportunity arises, if there are cervical spinal percussion turns that you can assist with, we will also mark that off, and then also demonstrating how to do ambulation, safe ambulation with a transfer belt.